Welcome, everybody. I'm David Belson from USC. Appreciate your attending. Thank you for attending. I think we have a very exciting program. I'm excited to see it myself. As the title says here, it's about learning from the pandemic to improve healthcare. This program is supported by the USC Gehr Center at the Keck School of Medicine, also by the USC Viterbi Engineering School, specifically the Daniel Epstein Department of Industrial and Systems Engineering, which is where I am, and also the Price School of Public Policy. I sincerely hope this program will be of interest, will be informative, will be interesting, will be useful. What we're dealing here, of course, with the pandemic, which is certainly not over and a great tragedy, no question about that, and certainly not over either. But there are things we can learn. Hopefully there's some things we can gain out of what's happened already, how the healthcare system has dealt with the problems that the pandemic presented. Hopefully it's not too soon, but we wanted to start the dialogue of what's going on here. And so we've got a number of great speakers today to talk about what we can learn from the pandemic. Overall, the program, we got a lot of speakers. We got about 20 speakers and moderators from all sorts of different directions in the healthcare system. And they're going to be speaking about various aspects of what's happened, what's been learned. Next slide. Myself, I'm in the engineering school. I'm a program director of a new program that we have in the at USC. It's actually from these three schools, from the Keck School of Medicine, Engineering School, Epstein Department of Industrial Engineering, and the Price School. It's a master's degree in healthcare systems management engineering. I've been working in healthcare for quite a long time, and thanks to my experience and working with different organizations, I was able to identify, I think, some really great speakers to help us in this area. So next slide. Today we have three speakers and a moderator from the Keck School of Medicine, and two very senior executives in large healthcare systems, and Randy Hall, who's done a great deal of research in patient flow and engineering generally, and past head of research for USC. Next slide. The next two meetings, the one on August 5th is on telemedicine. Certainly that's been a big impact on and been impacted by the pandemic. So we have doctors who have experienced telemedicine, what they learned from that experience, what ideas they have to make telemedicine function better, how to make it work better in the future. The next session on August 12th is more about how the system operates and performance people such as myself, what we do about making healthcare systems work better. And so we have a number of speakers on how performance can be improved and lessons learned to improve how the healthcare system works. Next slide. And then the final session on August 19th is a focus on supply chain. Certainly the supply chain shortages, PPE, and so on were impacted by the pandemic. And again, this is an area where we learn things, where we can now engineer a better system to some extent based on the impact of the pandemic. And so all of these sessions, again, address how the system responded to the pandemic and what's been learned to make things work better in the future, hopefully deal better in the future if these situations continue to go on and new ones arise. Next slide. As been announced, continuing education credit is available from your attendance at these sessions. There's a link there to submit your information. The CME unit will come from the Keck School of Medicine. If you have any questions, you can contact Alyssa at the link, the email address that's listed there. Next slide. So we've got a number of speakers and quite a large audience. So if you have questions, and we'd love to have them, about what you're hearing, what you'd like to know more about, something that you want to hear more about in terms of what the speakers covered, there's a Q&A button at the lower side of your screen. Click on that, enter your question, and we'll respond as best we can, each speaker. This will be the case for all 4 of the sessions in terms of Q&A. Next slide. So for today, our moderator is Michael Cousineau, who's at the Gear Center in the Keck School of Medicine. He's a physician, his practices in preventive medicine, and as you can see there on the bio, he's done a lot of work in public health and programs for disadvantaged, published a great deal of research. So he's very familiar with how the healthcare system works, and he will be moderating the speakers for this session. So Michael, go ahead.
Thank you. Thank you, Dr. Belson, and welcome to everybody to today's session. I want to start with a few things about the GARE Center. The GARE Family Center for Health System Science and Innovation is the name of our organization. It is in the Keck School of Medicine. It was started with a gift from the Norbert Gare Family Foundation. Norbert Gare was a business leader and philanthropist here in Los Angeles who, after he passed away, made a donation to the Keck School of Medicine to support this center and other work being done on things like leukemia and other diseases. It was coordinated through the work of the late Dr. David Goldstein, pictured here in the middle, who was also a leader here in the Keck School of Medicine, indeed at USC. And is now, the GARE Center is now under the leadership on your lower right of Dr. Sonali Saluja. Next. So our work, the work of the GARE Center focuses on 3 areas. One is health services research, educational programs, and an evidence-based practice center. Next. In terms of health services research, we do a lot of work in the area of healthcare disparities, efforts to try to, how do we reduce disparities in healthcare related to access to care, a lot of work in the area of cancer care and quality healthcare outcomes. Most recently, some work that we've done on access to COVID testing and vaccinations, substance abuse treatment, and pain management. We also do research on health policy, including changes in insurance coverage and the work of safety net providers and community-based organizations. And finally, in the area of delivery science, improving the way healthcare is delivered to improve equity in care and health outcomes, and particularly innovations in care, including telehealth. And we partnered a lot with Keck, the Department of Health Services, Ultimed, Department of Public Health, and other organizations. We also do a lot in the area in the space of education and training. We are developing a new curriculum for the Keck School of Medicine around the area of healthcare justice and systems of care. The longitudinal curriculum, which focuses on racism, structural competency, healthcare disparities, social determinants of health, and health system science. And we work with our students to share solutions and work towards health equity. Also, we just finished our 6th, I believe, what we call the GARE Student Summer Project, an innovators project where up to 15 students are brought in for 6 weeks to work with mentors around a very specific project. Often those resulted in abstracts and even published manuscripts. We have a evidence-based practice center, evidence-based review center run by Suzanne Hempel that received federal funding primarily to do systematic reviews around content areas. It's been very successful and a very important source of information globally around what works and what doesn't in the area of healthcare systems and science. So our first speaker is Dr. Brad Spellberg, who is the Chief Medical Officer of the Los Angeles County USC Medical Center. You can see he received his BA in molecular biology from UC Berkeley. attended medical school at UCLA, and has had many academic honors, including serving as the UCLA AOA chapter co-president and winning the prestigious Stafford Warren Award for the topic academic performance in his graduating class. He completed his residency in internal medicine, subspecialty in infectious disease at Harvard UCLA Medical Center. He's had extensive administrative and patient care activities. He has the NIH funding ranging from funding projects ranging from basic immunology and vaccinology to clinical outcomes and research. He's also an author. He's written an award-winning book, The Rising Plague, which I recommend. He wrote to inform the public about the crisis in antibiotic-resistant infections. And most recently, the book, Broken, Bankrupt, and Dying, which is a critical look at the U.S. healthcare system. I read that, I have used it on my courses, and I've read many, many books on healthcare reform. Dr. Spellberg has approached this with data, with humor, with stories, and makes a very compelling case. So I recommend that to anybody. But I'm really glad that he's here, Dr. Spellberg.
Thank you very much, Dr. Cousineau. I'm gonna put you on staff to do all my introductions from now on. Is that okay if I do that? Thank you for a wonderful introduction. I want to talk to you about two innovations that grew out of LAC+USC that enabled our hospital and the County of Los Angeles to survive the pandemic. And I guess the principles that underlie these innovations are, one, you need information to make real-time decisions about what's going on during something as dynamic as a public health pandemic. The idea that you can draft a plan and just stick to that plan and you're going to be fine is hilarious. It's the old saying, I think it was Sun Tzu, no battle plan survives first contact with the enemy, which Mike Tyson distilled down to everybody has a plan until you get punched in the mouth. Well, COVID punched us in the mouth. And so the first innovation I want to talk to you about is that let's go back in time to the end of February 2020, a year and a half ago. COVID had exploded in China. It was not yet substantively described in the United States. There were, if you had Googled it in mid-February 2020, you would have found a couple of newspaper headlines. This person may have had COVID. That person may have had COVID. This is really before Seattle blew up. Nobody knew if it was here, but everybody's worried about it. And in the end, there were debates, should we close the border? What's the response going to be? The Department of Health Services in LA County began to put teams together to figure out what we were going to do. And what became painfully clear is, to me at least, how could you decide what to do if you didn't know where the virus was? Is it in fact in LA County? If it is it barely in LA County, which would suggest that you could still do containment? Or was it actually already widespread in LA County, in which case containment was completely futile and we needed to focus on mitigation? We were absolutely flying completely blind, and yet teams were getting put together, plans were being drawn up, things were being mapped out. And I'm like, how can you draw plans when you don't even know what the heck we're at with this virus? So I went to my boss, Dr. Yi, and said, we need to start testing in community settings, at least in our urgent care and in our ED, people with mild influenza-like illnesses, to find out if it's already here, because if it is, we don't know it. And there was enormous resistance to this. You have to remember at that point, COVID tests were nearly impossible to get. Quest had not yet even launched its commercial service. We had a very limited allocation of the platforms that were available. We had a very limited allocation of test kits, and they were supposed to be used only for patients being admitted to the hospital with a severe respiratory illness. The CEOs of all the hospitals were furious at the concept of wasting their precious tests. on people who had mild disease that weren't even going to get hospitalized. So there was huge resistance in the system. And my own boss locally at LAC said, you know, you're going to need to get somebody downtown to have support for this, or we're not going to be able to get it done. So I went and talked to Dr. Yee, who you're going to be hearing from pretty soon. And Hal immediately understood what the concept was, that we can't properly plan. I don't care how many pages your playbook is. If you don't have accurate information as to where you are and what speed you're traveling, you can't safely land the plane. So he lined up behind me. He talked down the CEOs across the system. He got the support, and we lined up an alliance with the Department of Public Health. It turns out DrPH had been trying to get sentinel testing for 6 weeks, and they couldn't find any hospitals willing to do it. No hospital wanted to be the COVID hospital, right? Because if you did this, if you were the first hospital to do this, and you found 50 cases of COVID, the media would start reporting you're the COVID hospital, and patients wouldn't want to go to your hospital. So DrPH couldn't find a partner. When we reached out to them, they were delighted. They provided us the test kits, and they actually agreed, you know, to do the case finding follow-up and interview people who tested positive. So this took about 2 weeks to work out, and we started the testing the second week of March. At that point, Quest had just gone online, and it took 5 days. We sent the test down for people. So it was people who came up with an influenza-like illness. They all got tested in ED and urgent care who were not going to be admitted to the hospital, who were not terribly sick. And the test got sent to Quest 5 days later. We got our first batch back. We did a second series 2 days later. Quest took a week to get those test results back. And what we found was terrifying, which was that 8% of all influenza-like illnesses in people who did not look sick, had no known COVID contacts, and had no travel to a COVID endemic area, had COVID in LA County. And so at that point, when we saw the data, we were like, well, it's over. Okay, containment is done. If 8% of ILIs in the largest county in the United States are already COVID, you've already missed the boat on containment. It's already widespread. You better switch to mitigation right quick. Well, the department head for public health saw the data, talked to the county supervisors, talked to the state, and SF beat us to it. They locked down after we had done the gathering of samples, but we lost to SF because of Quest turnaround time. 2 days after SF locked down, LA locked down. And LA locked down because of those data. It was those data that allowed the department head of public health to convince politicians who did not want the economic fallout of a lockdown to understand that it was not going to be possible to contain this virus. The virus was already widespread, and the only hope was mitigation. After the lockdown, there was a dramatic decline in new cases, which it's impossible to say how many lives that saved. It certainly eventually, when we opened back up, ended up with a summer spike and then obviously the winter surge. But COVID would have torn through LA County at an exponential rate well before the June surge, had there not been that lockdown in place. So I think the first innovation is recognizing that you can't make plans. I mean, people were already doing it, but they were meaningless, useless plans. If you don't have information about where you are and how fast you're going, you cannot respond appropriately without information on the ground. Generals in combat have known this for centuries, but we had to be reminded about it in public health. The second innovation that I'll talk about came slightly later, which was, we thought during June, when we had about 130 COVIDs in the hospital, we thought that was a lot, and we were pretty scared. And we had done all the things you were supposed to do and canceled the surgeries and set up more isolation rooms and cohorted pay, all that stuff, the standard playbook stuff. That wasn't going to get us through, if things got worse. And so we took some feedback that we had heard anecdotally from Seattle and developed a home oxygen program. And so the point here was, what most of the COVID patients really needed was oxygen. We could get them the steroids orally, that was not a big deal. They didn't need other medical things. They didn't need surgery. They didn't need a bunch of fancy devices. They needed oxygen and steroids and time. And oxygen can be delivered at home. We do this for patients with COPD all the time. The question was, could you do it with someone as toxic and sick as patients that are acutely ill with COVID? We had heard anecdotes that some hospitals in Seattle had tried it. And so we decided that we were going to get overwhelmed because we all know direction, we all know what direction stuff flows. When the fit hits the shan, we know what direction that flows. It flows downhill, and the safety net hospitals are at the bottom of that hill. And we were the largest of those safety net hospitals. So we knew when COVID got bad, it was going to be us that was going to bear the brunt of it. We did not think we were going to be able to keep beds open, given the volumes of patients we were already seeing as cases rose. The home oxygen program was therefore intended as a survival mechanism. Can we avoid going to triage medicine where you have people in the ER and you line up and you go, you're going to die, you're going to die, you're going to die, we're going to give the vent to you? Were we going to be able to avoid that situation, which none of us wanted to be in? So we developed a very comprehensive home oxygen program with an educational handout for the patient to instruct them on how to position themselves and how to use their oxygen in multiple languages, and a video that they could watch that actually demonstrated how to manipulate the oxygen settings. We actually lined up a vendor that was eager to work with us and was willing to deliver oxygen concentrators to the home within 12 hours of hospital discharge, 24/7. So we could put tanks of oxygen in the emergency room. And if people needed 3 to 4 liters of oxygen or less, we could give them a tank to go home with, contact the vendor. Within 12 hours, the vendor would have gone to the house and swapped the tank out for a permanent oxygen concentrator that would not run out of oxygen. We then arranged for a phone follow-up. We pulled nurses from non-clinical care areas and gave them the responsibility of phone contacting all patients sent home within 12 to 18 hours of arrival at home, and then to make daily contact with them to make sure they were doing okay and give them advice on whether they should come back to the hospital or not, until such time as they were off the oxygen. So that program went live, probably mid-April to early May. There was a lot of angst. The ER was very nervous about sending people home. They were worried they were all going to die at home. This was pretty controversial, but we pushed forward. And that program now, at this point, at our hospital alone, has had something like 3,500 patients with COVID go home during the period of the pandemic on oxygen. 0 patients of those died at home. 0. I'm going to say that again. There were no deaths at home. Something like 3% of those people had to come back to the hospital. And there was a mortality rate of those patients whose disease had progressed, but none of them died in transit. And those people would have progressed whether they were in the hospital or at home. So this program at peak last June, we had 280 COVIDs in our hospital. That's nearly half our hospital beds. We had 80 in our ICU, and there were no beds left. There were no beds left. We were really on the precipice of triaging patients. We never quite made it to that point, but we were really, really close. And if we didn't have the home oxygen program, many patients would have been triaged. I would also point out that as the pandemic began to wane, and this program had spread across the other DHS hospitals as well, keeping them out of surge mode, triage mode. People began to ask questions like, well, why are we still doing this? We're not in surge anymore. Let's just leave everybody in the hospital. It's safer. And we had to go back and remind them. Actually, yes, it's true. The real impetus for this program was to keep the hospitals open and not triaging patients. But this actually is safer for patients to be at home than it is in the hospital. The hospital is a very dangerous place to be. There are so many things that go wrong in the hospitals that being in the hospital is the third leading cause of death in the United States. Think about that statistic for a minute. You die of medication errors, falls, pressure ulcers, various types of infections that you don't get when you're at home. So what we had to remind people is the core principles of high value care, right place, right cost, actually meant that we should be doing this even when we're not in surge mode, because it's actually more patient-centered and safer for the patients to be at home on oxygen with the nurse contacting them daily than it is sitting all day long in a hospital bed. And so that program continues and will continue in perpetuity for us, probably will get expanded to other illnesses as well. But it originated out of a survival mechanism in the heart of the pandemic. Those are the two innovations that I just wanted to talk through, and I'm happy to sort of open the floor up to discussion.
Thank you, Brad. Can you say whether or not the home oxygen program had been, I know you mentioned the other DHS hospitals, but have we seen this in other parts of the state or even parts of the country or the world even?
Yeah, so, oh yeah, thank you. That's a good point. So we had been hearing anecdotes, but there was no literature on it. There were no systemic programs described. And I think the anecdotes were people scrambling and jury rigging it together. I think ours was the first comprehensive described program with daily nurse contacts, a vendor swapping out the oxygen tank for a home concentrator, and the ability to discharge from the ED, because the ED doesn't typically store oxygen tanks for that purpose. Usually you get those from the inpatient side. So we stored and stocked oxygen tanks in the ED for that purpose. I think ours was the first. When we published it, about 2 weeks later, India began its big crisis. And it was a very sobering moment when the World Health Organization reached out and asked us for a copy of our video, our instructional handouts, and our policy, because the hospitals in India were going to need to be doing this kind of stuff. So it absolutely spread. It began to spread by word of mouth before publication, but after publication of the project, it absolutely did get adopted elsewhere.
Thank you. We have a question in the chat. It relates to something you mentioned earlier about the need for information, and this came from somebody who was asking about the work of the book by Michael Lewis, who had been critical of the CDC for being a little slow, maybe overly bureaucratic, reactive in terms of messaging to the public. And it made me, maybe this is not directly related to your topic, Brad, but when you mentioned the lack of information, was there a place where information was inaccurate or perhaps not helpful in helping you make decisions at the hospital?
Yeah, I mean, I don't think it's a secret. I think it's a publicly acknowledged fact that many people have been disappointed in the CDC for quite some time. This actually goes back to the Ebola outbreak of, I don't know when that was, 2015 or 16. It seems like a lifetime ago now. The CDC is a political organization. You know, it is run by a political appointee. It has to follow the instructions of the political administration in the White House. It isn't, you know, it's difficult, I think, for them to be nimble. It's difficult for them to make bold statements when politicians above them do not want bold statements made. I think that we found CDC guidance on this disease to be largely not useful. And we were making things up as we went based on information that we could glean and expertise that was internal to the DHS system. And I actually think, honestly, for a public hospital system, frankly, we did remarkably well. And Dr. Yee will probably talk more about that. But the fact that we never went into triage, and to have half your hospital beds taken up by COVID and 3/4 of your ICU beds, at peak, just to give people a sense, at peak, we were getting 60 new COVID patients per day
Wow.
at LAC+USC Medical Center. Where were they going to go?
Yeah.
60 new COVID patients per day. We were hanging on literally by our fingernails, but we made it and didn't triage people and provided really high quality care and frankly had a low mortality rate throughout the system.
Kyle asked about the financial impact, Brad, was it of not admitting patients and instead sending them home?
Yeah, I mean, so there's sort of good news and bad news. The good news is we're okay. And we're okay for two reasons. One is that we're a public hospital system. We don't make money from patient care. It is not our mission to make money from patient care. 90% of our patients either have Medicaid or no funding, and Medicaid pays 1/3 commercial rates. So you don't make money. You're there to lose money. Your system has been set up explicitly to be subsidized by the taxpayers because you can't make money taking care of Medicaid patients. It's impossible, okay? So decreasing the number of patients who we lost money on didn't hurt quite as much as private hospitals that make a ton of money surgerizing patients, okay? That's the good news about why we've ended up okay. The bad news about why we've ended up okay is because we still had to get bailed out like everybody else.
Yeah.
If the feds had not put trillions of dollars into COVID response, all hospitals would have gone under, and we would have gone under later than the private hospitals, but we absolutely would have gone under. Our costs skyrocketed just from PPE alone. And while we lose money doing patient care, you are losing revenue. Your costs are staying fixed because you're not laying off your staff, but you're losing revenue from having fewer Medicaid patients in your hospital. So we still did need to be bailed out like everybody else. And that's the reason we survived. The feds are the reason we survived financially.
Thank you.
I have a question.
David, go ahead.
Brad, the home oxygen program was a result of COVID-19, but the next pandemic or our next crisis is going to be different. Is it possible to be prepared to have the system in place to respond to such emergencies, or do you just have to wait till you're punched in the face?
Yeah, that's a great question. And I'd be curious what Dr. Yee's answer is. He and I usually think alike on stuff, which means we think differently than most other people because we're both weird. But my answer is that you can be conceptually prepared, but you cannot be prepared for the facts and details. So if the next pandemic is a respiratory pandemic, we'll probably be able to do well with our home oxygen program. I'll point out the SARS-CoV-1 had a 30% mortality rate. People think SARS-CoV-2 was bad? No. SARS-CoV-1 was much deadlier. The advantage of SARS-CoV-1 was it was less contagious. But I don't think home oxygen would have worked that well for a disease where 30% of people are dying because they all ended up on mechanical ventilation. And we haven't figured out how to do home mechanical ventilation yet. We can do home oxygen for people that don't need more than 3 to 4 liters per minute of oxygen. So the details matter, and you can't predict the details. And so I'll go back to, at the time I was talking to Dr. Yee about supporting the testing that established widespread COVID in LA County much earlier than anyone had realized. We already had giant books of plans that had been drawn up. There were doctors and nurses all over the system and hospitals drawing up all these plans and spending hours on these plans and stuff. And I was sitting back going, what are you guys doing? None of this is going to matter in 3 months because it's all going to change. So the analogy that I used was I don't know if people are familiar with Hadrian's Wall in England. It's this wall that transects the entire width of the country in the north, and it was built by the Emperor Hadrian. And scholars have debated for years why they built the Hadrian's Wall. And one theory was to keep the Picts out. They were attacking from the north. There were no attacks at the time they built the wall. That wasn't the reason. Maybe it was to control trade and stuff. There was no trade. The real reason Hadrian built that wall is because Roman legions that were bored had a nasty tendency to try to overthrow the emperor. So he wanted to keep them busy. And so he had them build this wall to keep them busy, to keep them out of trouble. The real value of all that planning early on was there were some very anxious physicians, nurses, residents, and everybody. And this was a way for them to burn off all that excess energy while we could be productive behind the scenes. That's the way I look at it. Planning is important to lay out the concepts of where you're going to go, but you have to be prepared to nimbly adjust your plans very rapidly, and no plan drawn up before you've met the enemy is going to survive that first contact with the enemy. As I say, generals have known this since Sun Tzu.
So we have a question about talking about other barriers to spreading and having adopted the home oxygen system. How would you suggest that the healthcare system changes before hospitals become dinosaurs? And I'm wondering, as an added to that question, Brad, whether or not we need to think about the upstream payers of this. You know, the insurance companies are paying for inpatient care, but not as much for outpatient care. And maybe there's a way to rethink the way we pay for care.
Yeah, so there are several pieces to this. One, I think Dr. Yee is going to talk about was the ability to put a home oxygen program in place from start to finish, a brand new program in the span of 3 weeks, and then spread it to the DHS hospitals in a month. That wouldn't have been possible pre-COVID. That was possible because of the changes Dr. Yee made to allow us to act nimbly as a system. And he'll talk more about that. So there had to be authority procedural changes to allow rapid innovations to be implemented and spread in order for that to work just operationally. As far as hospitals becoming dinosaurs, we're very aware of that. Again, Dr. Yee is one of the world's experts. He can talk to you about e-consult, which was a way for dinosaur hospitals to markedly improve the efficiency with which they deliver specialty care throughout a health system. Home health, the ability to deliver care at home is probably one of the, I mean, we know that telehealth is the current rage that COVID put into place. Home health care is probably going to be the next rage operationally. And home oxygen is a form of that. It was dipping our toe into the water. Pushing care out of the hospital, right care, right place, right cost, is something that we're all thinking more and more and more about. As far as the payers, you're absolutely right, Michael. We can't do innovative care if the payers won't pay for that care. And so there has to be health system and finance level changes that match that. Fortunately, in the safety net, much of our revenue comes from supplemental payments, which do not depend on the nature of the care delivered. So we're a little bit, we actually have that unique advantage in the safety net that we are not quite as linked to fee for service, where if you don't do the surgery, you don't get paid. If there's not a patient in the hospital bed, you don't get paid. That was actually a unique advantage for our system, I would say.
So I was involved in a committee at the state level for several years around how we would pay for telehealth. And we had committees and subcommittees and legislation that passed hearings, subcommittee hearings, proposals that were modified. Nothing happened for years. And then COVID hit and literally it happened overnight.
Yeah. So yes, the Chinese character for crisis and opportunity is the same.
Yeah.
And as I've been taught by my mentor and boss, who's going to speak soon, never let a crisis go unused.
Good
It's
point.
amazing how much more rapidly you can change things when everybody is focused on one purpose, instead of everybody scattering and having 50 priorities they all want done. If everybody's focused on one purpose, you can cut through much of the bureaucracy and get stuff done.
A quick question. What's the connection between the home oxygen program and telemedicine? Were the home oxygen patients online?
That's a great question. We did not build remote monitoring in for a variety of reasons. One of which was at the time we launched, we didn't have home monitoring devices in play, and the telemedicine simplifications that came along subsequently were not in place operationally or at the payer level when we launched home oxygen. So what we did give is home O2 sensors that people could monitor. The handouts, the videos, and the nurses. So the handouts and videos told the patient how to check that monitor and what it meant. And the nurses would check in and say, what's the number? Oh, you're good, you're fine, keep going. Or, you know, that number is really low. We think you need to come back to the ER. So we were doing remote monitoring, not via telemedicine, but via phone contact and via education of the patient so they could do it themselves.
Kyle asked about what do we do to prevent in the future, any future problem, the issue that you talked about, Brad, in terms of it being labeled a COVID hospital. You know, I know there was some talk about the old St. Vincent's Hospital becoming a COVID hospital. I don't know what happened to that, but what are we concerned about that for the future?
I'm not. I've learned from Mitch and Hal to own who we are. Yeah, we're the COVID hospital. We figured out how to solve COVID. If you have a problem, you come to us.
Yeah.
We figured out how to do it safely. So you own it. You get out in front of it. You don't hide from it. You know, but we want to get to a point where we're not afraid of who we are. We're not afraid of what we have to do, and that you don't shrink from doing the right thing because you're afraid of the PR. You get ahead of the PR. You explain, and you use your media outreach to explain why this is important, why you've done it. So no, I think if hospitals are still in that place, and there are still absolutely private hospitals, they need to get on board, right? I mean, that's a failing of leadership at those hospitals.
Brad, you mentioned the relationship with Department of Public Health early on and how you turned to them. How has this affected the relationship between the hospital and public health, you know, formal public health department work, both in terms of LA County, but also we also have two city health departments, Pasadena and Long Beach. Do you see this as a game changer in terms of your relationships with public health?
Well, I would say, and you know, Dr. Yee has a higher level view of this than me at the system level. I would say that the relationships between DHS and DPH were better, certainly to me, from my view standpoint, you know, closer, more collaborative than I had seen in prior decades in the system. So I think, again, when you have a crisis, everybody draws together to solve that crisis, and you maybe can start building some bridges that could potentially last beyond the time of that crisis.
Thank you. Good. Are there any more OC? Somebody asked about, can you talk about your lessons on partnering with varied stakeholders to spread innovations?
Yeah. You have to have engaged people at each, you know, so if you want to partner, you have to have people who are willing, they have to be aligned in thinking. And if you don't have those people that are aligned in thinking, you need to go one level up in the org chart to figure out how to get somebody in that place. Now, guess who was one level up in the org chart for me? It was Dr. Yee. So when we had resistance at hospitals, sister hospitals, to spreading home oxygen, we were able to work through the systems that Dr. Yee has put into place, system-wide committees, and if necessary, sort of go over the head of the people that were getting in the way to allow the innovation to spread.
Mm-hmm. We just have time for one more question. Is there anybody out there? If not, maybe Brad, I could ask you one last question about the impact that it had on training programs, the work of residents, and how that's affected the work of residency and training going forward.
You know, In one sense, it was highly variable. There were specific specialties that got hit much more heavily by COVID than other specialties, as you might imagine. If you're doing fewer surgeries, right, you're doing fewer biopsies, then people who make a living doing surgeries and biopsies are having less exposure, less case volumes, less work. If you're working in a respiratory ICU, you were getting crushed. I mean, just getting absolutely crushed. And so the workload impact varied by specialty. The one thing that did not vary, and I will admit naively not recognizing this was going to happen, the level of anxiety everywhere, whether people were getting hit or not, even the pathologist, everybody was off the charts, and it transmorphed to distrust and anger. There were incredible amounts of anger and distrust that took a lot of person hours, just countless person hours, to reassure, to soothe. And I will say, to try not to lose our own tempers, my own tempers in particular, being accused of things when you know we're working our butts off to try to make this better and try, but it's fear. It was just primal, raw fear. And it was everywhere. And that was actually probably the single most stressful thing for me, was to deal with everybody's fear throughout the system, throughout the hospital. And that affected trainees at all levels.
Yeah. We have one last question in the chat here. Are there any thoughts to distributing resources proportionally to people who were disproportionately affected by COVID? It seems like at one point you had at least half of your patients who were COVID patients. It seems like you were doing that.
Well, when you say, so one way.
That's what somebody, Asan, am I saying that correct?
One way to interpret that question is about health equity across a population. So it's important to remember, we're the safety net. We are caring for the people that other folks will not care for. 80% of our patients are minorities. Okay, 60% don't speak English. So all of our resources went to provide care for the most vulnerable members of the society in LA County, in the county area. And our challenge was, and this was very challenging for physicians, as you might imagine, was we have to make sure we provide the most care the best way we can with the fixed resources available. And so we had to make some tough calls. Sorry, we're not doing ECMO, okay? There are no randomized controlled trials that show that ECMO actually is more effective than other treatments. Big academic medical centers like to brag about doing ECMO as saving lives, but there are no data to actually demonstrate that. And when I start a patient on ECMO, I have to close the neighboring ICU bed down because I don't have enough nurses to staff that bed. And if I've got 10 people in the ER who need that bed, I can't punish those 10 patients to put one patient upstairs on something that people think may be better but can't demonstrate it. So our challenge was not rationing care. Our challenge was exactly that, distributing care to do the most good for the most people with the resources that were available. And that's exactly what we did.
How did you do the home oxygen program for people who are experiencing homelessness?
We were able to get them COVID housing, and we were able to do home oxygen in COVID housing, which was awesome. We still were able to make contact with them, with our nurses that were doing daily follow-up.
Terrific. Well, thank you, Dr. Spellberg. That was amazing. You did mention you published the home oxygen program. Is that something we could share?
Yeah, I sent the papers. I think I sent them to Alyssa.
Okay.
So
terrific.
both of those projects, both the testing in the urgent care and EDs, that was published in JAMA. And then the home oxygen program was published in JAMA Open Network. And I sent both those papers to Alyssa. They can be distributed. Yep.
Great. Thank you. Thank you very much. Well, thank you so much, Dr. Spellberg. It was terrific. Okay, so I'd like to now turn to our next speaker, who is Dr. Randolph Hall. Randy Hall from USC. He's the past vice president of research for the university where I've met him. He's been involved in research initiatives across the university. And his own work has really focused on the work of hospitals and systems of care within hospitals. And so we're really pleased that he's been able to join us today to talk about his work and his perspective on this. And I believe, Randy, you have your own slides you wanted to share.
That's correct. And thank you, Michael, for that introduction. And thank you, Dr. Spellberg, for all the innovative work of LA County Hospital, saving lives during COVID. In his presentation, Dr. Spellberg spoke about February of 2020. And I'll just mention a bit about that. On February 27th of 2020, I was at a meeting in the White House in which it gathered much of the scientific leadership of academic institutions across the country, as well as NIH and other funding agencies. The topic of that was data sharing. How can we advance research by sharing data amongst researchers to be more effective and more accurate? And there was discussion at that meeting about how COVID might be a case study for that. And I'm glad there were accomplishments in that direction. But simultaneously, I'll comment, in that meeting, we were sitting within 6 inches of each other in a very crowded room with 0 protocols in place to reduce any spread of the disease. And I can say at that point of time, the leadership had not recognized that importance, but they did about 2 weeks later. So things did change very rapidly. So I'm going to share my screen here to get started. And now you should see an introduction to my presentation.
Yes.
Okay. So I'm going to talk about my own background and why an engineer is involved in studying healthcare. And it goes back to this book, which I published in 1990, so about 30 years ago, called Queuing Methods for Services and Manufacturing. Queuing is a study of delays and waiting, and it's been studied for many, many decades. But traditionally, the frame of mind for the research is studying it as a stochastic process, meaning a random process, where you want to determine how much capacity to provide in anticipation of random fluctuations that occur in systems. I took a different point of view in this book, and that was that much of what occurs in delay and waiting is not just random, it's predictable. And really the aim is, how do we plan for the predictable events that cause waiting and delay to occur? In the case of COVID, as I'll be talking about later, there is certainly unpredictability, but there is also some predictability. And how do we take advantage of that predictability to run systems? So how I got into healthcare was maybe a decade later. After publishing this book, I was contacted by Carol Harridan, was working at the Institute for Healthcare Improvement, and they had started an initiative on patient flow. I had never heard the words patient flow prior to hearing from her, but what I discovered was that my book was being used by that patient flow initiative as a basis for improving the delivery of care in healthcare systems. And I became involved in IHI, and I eventually edited this volume, Patient Flow, Reducing Delay in Healthcare Delivery. And in this book, we brought together perspectives of clinicians as well as engineers, data scientists, statisticians in a comprehensive way, as how do we improve delivery by using scientific methods to understand what causes the variation and delays in systems. And then there was a follow-on book that I edited called Handbook of Healthcare System Scheduling, which got more into the details of how we schedule patients, how do we schedule employees, workers, et cetera. Now, I came into contact with David Belson in a project around that time. We were contacted by Tom Garthwaite from DHS, who was leading it then, and he was very interested in system improvement in the LA County health system. And from this, Dave, I, and a few others engaged in a project studying healthcare delivery through the LA County Hospital at USC LA County Hospital, not the current hospital, but the old hospital. And in this work, we took a comprehensive look at the flow of patients from entry to exit in that hospital, what caused delays, what services were patients receiving in different places in that system. It was published in a report and was published in this paper, which appeared in the book on patient flow. And this was really our big attempt at using engineering methods to improve healthcare delivery. And I bring this up in part because the theme of today's session, Learning from the Pandemic, is merging the talents that we see in the Keck School of Medicine with the engineering school as well as policy. And a clinical approach combined with an engineering approach and systems approach is very beneficial in this. So I'm going to talk about some of the basics of patient flow. What is it? How do we address that in healthcare systems? And then I'll talk more specifically about COVID and the implications of COVID. But patient flow is a process and steps by which patients receive healthcare services with the aim of efficiently providing those services when and where needed by the patient. Really, we're looking for alignment of those services with what the patients need so that they don't encounter long delays and so that they receive the patient where it's most appropriate, receive the care where it's most appropriate to receive that care. And we look at it from a hierarchy. So this is what I call the hierarchy of delay in terms of matching the time and place with needs. Perpetual, varying, and random. And all these things exist within healthcare systems. Perpetual means there's inadequate capacity and it's consistently inadequate, creating perpetual delays. If you're a patient, you cannot get the service exactly when you need it. There is a queue to get to see the doctor. There's a queue receiving the service once you come to the doctor. And this is, of course, is very unfortunate and the worst state to be in. Secondly, varying, where capacity is predictably not aligned with the variability in needs. Patient need care at different days of the week, different times of the day, different places, and the capacity just doesn't match up with that. And so this leads to a time varying, a place varying delay in the system. Sometimes you wait, but much of the time you do. And the last is the random, and that's largely a mismatch between capacity and need that is unpredictable. And so not everything can be predicted. We don't know exactly how many patients will present on a particular day and exactly when they will present. But nevertheless, there are patterns. And if you take advantage of the patterns, you can better deliver the care. So in an optimal situation, the care is timely and appropriate, meeting the patient needs, that you really see these synchronize one with the other. And the wait once arriving for care is short, safe, and pleasant, that you come to the doctor at a particular time and you see that doctor within minutes, or you receive another clinician within minutes. You're not waiting hours for that service. And capacity is also fully utilized. And so while you want to serve patients in a timely fashion, you also don't want to waste resources. And that requires a synchronization between the patients when the patients present and the planning for the capacity to serve those patients so that the capacity is not idled often. It might be idled some of the time, but it's not idled often. When a shortage is perpetual, care is significantly delayed. Some patients will give up or never receive service. If the delay is too long, they may never receive that care because it isn't timely, and the patients will suffer. So what are the basic strategies? And so I'm not yet talking about COVID in particular, but the basic strategies: controlling the supply in terms of workforce availability and scheduling, facilities planning, supplies and equipment, making sure they're adequate for anticipated needs and demand. On the patient side, prevention, so that patients might not need healthcare. They might not need to go to a doctor's office. Appointment scheduling and follow-up by follow-up, helping ensure the patient shows up for a scheduled appointment so that doesn't become wasted capacity. Sometimes pricing. I will comment that in most services we receive, less so in healthcare, pricing is a way to control the demand and aligning demand with supply. We certainly see it in things like the airline industry or in things like hotels, where the pricing varies in accordance with demand, and that way things align better. And then also synchronization through triage processes. So by that, I'm largely meaning prioritization and coordination of related services, that a patient isn't just seeing one doctor or going to one office, but there's a lot of different things that need to be synchronized with each other, so that delay does not occur as you go from one place to another as a patient. So what about COVID-19? So what is different here, and how do we anticipate COVID-19, and how do we respond to that? Now, Dr. Spellberg already talked about some of the things, providing oxygen at home as a way to enhance the supply of healthcare beyond what can be done in a hospital itself. But in terms of capacity, there are new resource requirements for in-person, PPE being an example, or other protocols that may demand more labor, more workers in order to serve those patients than would normally be the case. Changes in service provision through telemedicine occurring. Supply shortages are balancing the supplies that are needed for care with the arrival of patients and the occurrence of disease. Staff shortages partly as a result of the disease. Demand. Certainly there was substantial deferred care, possibly resulting in future needs. By deferring care, perhaps the patient becomes more ill, perhaps it is just a question of delay. The demand being hard to predict. Public behavior affecting transmission and creating surges. The link between behavior outside the healthcare system and what the healthcare experience is very important. Controlling infections within facilities also, so that the healthcare system itself doesn't become a source of additional transmission of the disease. And then also synchronization, comorbidities may exist, and also the process of discharging infectious patients. And do they get discharged to home, as perhaps was done in the LA County system, or is there some other care provider that comes afterwards? So this is a diagram, a patient flow diagram, exploring some of the elements by which a patient, either COVID or non-COVID, interacts with the healthcare system, and how the COVID cases may interact with the non-COVID cases. And so when transmission occurs, new cases occur, and that's the orange box on the left. Well, in uninfected people may become ill themselves, so non-COVID cases may occur. Emergent or scheduled in the yellow box. Yellow boxes may result in hospitalization. Orange boxes may originate with infections that occur at one's residence. They may progress to requiring hospitalization. In some places, less so in the United States, infected patients were quarantined, aggressively quarantined, to separate them from other people who might contract the disease. Hospitalization requires resources and subsequent to discharge, post-hospitalization facility. Possibly that's a home, possibly that's some other type of healthcare facility. And as outcomes, fatality or recovery. Of course, prolonged illness is another possibility. And then recovered patients may provide the ability to provide antibodies for plasma therapy as well. So providing that feedback mechanism. So this is one way to look at the patient flows in a COVID environment. And then one thinks about all those boxes and colors and what kinds of interventions might occur. And I'm not going to go through all the things on this diagram, but I mainly want to point out is the interventions occur in many ways and in many places. At home, after an infection, prior to infection, preventing new infections, quarantine facilities, hospitalized, post-hospitalization. And these need to be thought of as an integrated system. It's not just the hospital, it's what occurs outside the hospital. It also occurs in the behavior of people who are not yet ill, but may become ill and may become the transmitters of disease. In all of these cases, we also need to think of what a success looks like. And we need to reduce the occurrence of things, and we need to do it equitably. Cases rate acceleration of new cases, R value representing the degree of transmission of the disease, and so on. Non-COVID hospitalization, and that's a way to make capacity by delaying surgeries. You may make capacity available for COVID patients in the hospital beds, but there are costs in doing that, potential costs to the non-COVID patients, financial costs too. And so maybe not so much for LA County Hospital, but certainly for the private serving hospitals, including Keck Medicine of USC, delayed surgeries does have financial consequences to the institutions. And of course, availability of resources matter. And so across all of these elements, we need to think of what are the interventions and what are the consequences of those interventions that may occur. So my main focus today is how do we look at the data and what does the data tell us about patient flow, and how do we plan for patient flow looking at data on infections or maybe deaths, hospitalizations, and so on. And so we can look at the case data as a measure of prevalence of disease, current infections, but as Dr. Spellberg already mentioned, especially earlier in the pandemic, testing was not widespread and it was selectively biased towards the most ill people. So the most likely people to be tested were those already presenting in hospital with severe symptoms. What is the susceptible population lacking immunity or the degree of immunity? What is the level of contact between susceptible and infectious people? Proximity, duration, environment, what are the hygiene methods in place? So all these things affect the transmission of the disease and the subsequent presentation for care and the outcomes that may occur from the disease. And the thing I want to emphasize, if this isn't already apparent, this is a very nonlinear process. And we have seen this at different ways of the pandemic, is how it is nonlinear and how things can grow very rapidly due to fairly subtle changes in behavior of individuals. And so I'll just give a few number cases, and these are not too far off from what actually occurred during the pandemic. And so suppose new cases are growing at 5% per day. What does that result in? One case becomes 4 cases, new cases per day in a month, 80 new cases per day in 3 months, 7,200 cases per day in 6 months, and 600,000 per day in 9 months. So over a period of 6 to 9 months with that rate of growth, it explodes, absolutely explodes, and to some degree, even after 3 months. What if it's 8% per day? Then we see 10 new cases per day in 1 month, 1,000 per day in 3 months, and 1.2 million per day in 6 months. Now, the reality is once you get to numbers like that, so many people have been infected that the susceptibility to the disease has diminished. But 8% and 5% per day growth is not out of line with what we experienced. And in LA County, if you looked at the surge in the November, December, up to mid-January, we were growing at about 5% a day. But suddenly it flipped. And in mid-January, it became a decline of about 5% per day. And then it all trailed off for the next several months. So things can change fairly rapidly. And the main thing is because it's nonlinear, it can accelerate rapidly. It can also decelerate rapidly. So how do you stop the cycle of growth? Reducing the susceptible population through acquired immunity or vaccination, ideally vaccination rather than illness, and changing collective behavior to reduce contact. And I think that's the most important thing. I saw a question from Vicki Beer, who is associated with our CREATE Center, about how do we communicate. And I think the main point about communication is our behavior is not just about outcomes for ourselves, it's about outcomes for everyone. And the more we are vulnerable, then the more others are vulnerable, and the more likely we can move from a case of declining cases to accelerating cases. So the opposite, how does the cycle of growth begin, is changing collective behavior to increase contact. Around mid-June, we started growing again, and that could be for several factors. It could be because of variant, but it also coincided to relaxation of rules in terms of contact and hygiene. And so both could be reasons why we've experienced growth for the last month or so in LA County and many other places around the country. And so that can restart the cycle of growth as we had a decline earlier. Comment a little bit about importation of disease. And so this was something that Dr. Spellberg spoke to, that where were we in February of 2020 in LA County? Were we a region like the center one without infections, and where we had to worry about the importation of those infections from elsewhere, either adjacent regions or perhaps other parts of the world? In which case a barrier around the region might be an appropriate way to control it. Or was that already occurring, and were we moving into a different phase where once it already occurs in that region, that the community spread is probably more important than what is coming from outside? And so eventually, once it is prevalent, then importation has a more insignificant effect on what occurs in a region, because you're getting more infections from people who are already there than people who are coming in. And you then become the spreader to somewhere else as well. So in terms of our research, we are looking at an integrated modeling framework, looking at how we both transmit disease as a population, and then how do we respond to that with public health provision and resources. Particularly, we're looking more for the next pandemic than for the current one, because we're well into this current pandemic, is how do we allocate vaccines effectively and equitably? And so one balance is between those who are already, who are most vulnerable to serious illness and death, protecting them, versus protecting the spread of the disease to others, which may then in the long run affect even more people. And you could think one example of that is back in January of this year, different regions of the country were experiencing COVID at different rates. And should we have at that time administered more vaccines in a state like Michigan, which was experiencing it more than other states, so that we could stop the spread there and reprioritize that way? And I'll give that just as an example of that question. To do this well is a very complicated mathematical question. I'm not going to get into the details of that, but it's a point of ongoing work. I'm going to talk a little bit more about the data. We have 2 papers looking at tracking diseases at the national level. We're more about comparing states than comparing regions, such as LA County. One thing we're looking at is how the reported cases and reported deaths vary over time. This curve here compares cumulative deaths to cumulative cases. And this is normalized, so it's on a scale of 0 to 1. So if you're looking at how these distribute over time, one thing we have seen throughout much of the pandemic is that reported deaths, or counts of deaths are distributed earlier than reported cases. And logically, why would that occur? Because in reality, somebody doesn't die before they have a case or they have an infection. But early in the pandemic, it's very clear that cases and deaths were not equally counted. And they still are not equally counted. Deaths are more likely to be reported than a case, or an infection, I should say. But because of the unequal counting process or testing process, we see some odd distributions. We are measuring how that's distributed. We're also measuring the average day of case and death across states. I'm going to just call out New York because it's perhaps the most extreme example, because they experienced the pandemic so early. And so on this scale of days, this is a cumulative count of deaths and cumulative count of cases. And so proportionately, deaths early on were 2 to 1 above cases in the state of New York. And that is almost surely because cases were not being counted as deaths were being counted. There wasn't the same level of testing occurring as there was reporting of deaths. We also see this is the average day of case and death. The average reported day of a case in New York, and this is as of the end of February, was day 230, starting with March 1st. And the average day of death was about a day 180. It's about a 50-day difference or so, deaths occurring 50 days earlier than cases in the state of New York. And it's quite a significant difference. This is the distribution counted. This is counted as of the end of February of the average day of case by state. And we're comparing 3 different data sources here. We have the green is an estimate produced by something called COVID-19 projections. And these represent COVID-19 estimate as well as CDC data. And this is a probability distribution of the average day. And it varies from about day 220 to day 280. COVID-19 projections, by contrast, is about day 150 to day 260 for case. And so what you'll see is that the average day of case is well beyond the middle of the pandemic. So there's a heavy weighting towards later. But COVID-19 projections estimates that those cases occurred quite a bit earlier in the pandemic. This is a state-by-state comparison of COVID-19 projections to CDC data. The lighter faded states show an earlier average day. So the average day in the New York region was much earlier by COVID-19 projections, as well as CDC. But we're talking about a few months in rather than beyond the middle. So there's quite a significant difference resulting from these 2 different ways of both counting and estimating cases. And this is a table showing some data as well. I'm going to skip that over in the interest of time. But just to mention one other thing is that we've used estimation methods for the R value over the course of the pandemic. And this was estimated in the summer of 2020. And what we found for both New York and for California, the effective R value had declined significantly in the course of a period of about a month from March to April, from 3+ to about a half. And if you're at about a 3+, you are growing that pandemic very rapidly. And if it's below 1, it's more declining. And so as a comment, in the summer of 2020, most of the country was declining in the experience of reported cases in this country. That didn't last for long. It switched towards the end of summer. So effectively the R value climbed back above 1 again. But at that period of time, with the strong controls in place, in many ways we were succeeding against the pandemic with economic costs associated with that, but we were succeeding at that period of time. So takeaways. So in terms of patient flow options, just to keep it at the most basic level, supply, demand, and synchronization are the general choices. And that can be applied to the process of COVID transmission, non-COVID cases, at home, quarantined patients, hospitalized, and post-hospitalization. And so there's strategies that can be applied to each. Demand is highly sensitive to collective behavior. It's not just about the individual, it's about group behavior. And it's really the group behavior that has mattered. Surges have been experienced at different times at different places. It's very clear different parts of the countries have experienced the disease differently by location and by time. And behavior has changed, and it will change the course of the pandemic, can cause it to accelerate or decelerate. Declining rate of growth doesn't mean we stop the pandemic. And maybe that's the most misunderstood aspect from the general public, is that we're trying to stop the acceleration and we're trying to turn it to deceleration, maybe not absolutely stopping it. And it is important to think of this as a system. And here's a way of diagramming it. Just a couple more slides. We have a website, COVID-19 data source, that talks about our research. I can't end without talking about Daniel J. Epstein. Just about 20 years ago, he committed $10 million to the university so that the Epstein department could be the first named academic department at USC. We're almost up to the 20th anniversary of that. And you'll see Daniel Epstein in the name of the department. And he has also supported our health program, health systems program that David Belson is leading. So we thank him twice for that. And then secondly, I've gone back to being director of the CRATE Center, and CRATE has started as a center to study terrorism, but in fact, we study threats of all sorts at this point, human cause and non-human cause. COVID is in some ways natural for us because it's really a blend of human behavior and naturally occurring behavior. You know, maybe humans didn't create this disease, but they certainly have affected how it has spread and has affected the consequences of this disease. And that includes not just health outcomes, it also includes economic outcomes. And our center looks at economics as well as life and livelihood. And this has been the supporters of our work, Spellberg Innovation Fund at USC and Center for Undergraduate Research at USC. And with that, I am going to stop sharing.
Thank you.
And if there are time for questions, I can take questions.
I have one question. You know, during the pandemic continuing today, there's a lot of discussion about that certainly COVID-19 did not affect people the same. There's a lot of disparities in terms of who gets it and who dies from it, who gets hospitalized, who dies from it. I guess my question is when we look at the systems change I think you're proposing, particularly our connections to public health population data sets, how do we better address that? How do we better connect the dots between service providers, public health, population estimates, as a way to really reduce the disparities that we see? Because I think we're all very, very concerned about that.
Yeah, and really there are two basic pieces of it. And what are the healthcare resources that treat patients once they have contracted it? And the other is how do we prevent the spread of that disease? The spread of the disease is very complicated. I'm sorry, I don't have great solutions for the fundamental issues, which are how people experience their life. What is their living environment? What is their work environment? And those are absolutely connected to the spread of disease. If I'm living in a crowded household, maybe with multiple families, as occurs throughout Los Angeles, I am very exposed to other people compared to, you know, the life I lead where, you know, I'm around my wife or maybe kids and I have that as my home. And then if I am called on to go to work every day where I'm encountering the general public, that's another point of exposure. But we have to absolutely think about the living environments that people have, and particularly for contagious diseases. And then as far as availability of the resources, I do think we generally have done a good job in making vaccines available. Now, it hasn't been perfect, particularly maybe for the first, maybe for a couple months, but we have as a nation made a commitment that vaccines should be available to everyone, and we have made them widely available. And so we've changed from a situation where we have limited supply to maybe we have limited willpower of individuals to take advantage of what we have available. And so that's a matter of changing attitudes. Now, the other aspect of how do we provide quality care for those who have contracted the disease and serious illness. And I have to say, you know, Dr. Spellberg gave a perfect example of how to do that. And that's being creative in how we provide quality care, maybe even better care, by imagining different ways of delivering it. And being in the hospital is not necessarily the place to be. It's a very expensive place to be and it has very limited capacity. But we need to recognize that we have ways to provide better care, which are not necessarily what feels like the gold star type of care.
Okay, any other
Yeah,
questions?
I have a question.
Yeah, David.
Randy, in Dr. Spellberg's talk before you, he said that the planning function, emergency planning function, sounded like he didn't feel was terribly productive. What was your take on his comment? Is planning for these things useful? Is it important?
Well, I do think planning is important, but I'm not sure that's entirely what he was saying. He was saying that you need to be adaptable in your planning. And so what you thought things would be a week ago or 2 weeks ago may not turn out to be the reality. And so really this is a matter of contingency planning. And so, and I might go back to the communication question. And this is where I don't think the health communication was well conceived. And we'll go back to maybe the most controversial thing, and that is masking. And you may recall early in the pandemic, the advice was basically you don't really need to mask, save those masks for the healthcare providers. Well, and that was based on what was known at the time, but it wasn't based on the uncertainties about what was known at that time. And at that time, we didn't know for sure that you didn't need to wear a mask. It just that some of the evidence, maybe you didn't need to wear a mask. Well, if you think about the uncertainties and the outcomes of those uncertainties, if there was a good chance that masking would help, and all the public had to do was, put together a cloth mask, and that would make a difference. And that would make a very big difference early on in the pandemic. That would have been a better message than saying, don't bother wearing a mask. And so, unfortunately, I think we don't think enough about the uncertainties in our planning. We think about where we are at that moment, and what is that best information, not all the different possibilities of what will happen next. And so we need to have that kind of resilience and contingency planning. If A happens, do this, if B happens, do something else, and so on. And so that's the way planning needs to work.
Listen, do we have time for one more question, or do we need to, one more question? Yeah.
Hi, Brandy. I had a question. Thank you so much for your talk. I had a question about testing. And we actually did a survey of Los Angeles County adults and asked about challenges to getting tested for COVID. And lots of people reported barriers, despite the fact that we had free testing, things like long wait times, for the test, or the test not even coming back in time for it to matter. So from your kind of industrial engineering perspective, what could we maybe have done differently or better?
Yeah, well, there certainly were points in time when testing was in short supply and it was hard to obtain. And clearly that was true around the surge in December and in January. And so, we need to have both more outlets and then capacity, and the capacity at multiple levels. It's at the place of testing, and then it's also at the lab that analyzes the tests. And they absolutely do need to be timely. So your observation is, if you get the results back in, say, 5 days, maybe it doesn't matter. And maybe just the existence of needing a test means you need to isolate. So your action is the same either way. And there's some logic to that, to say, if I have some symptoms, why do I go in and get tested where I might even expose more people rather than just self-isolated at that point in time? And so it's not, the public reaction is not illogical, but ultimately it's a matter of having the capacity at the places where patients can most conveniently get the test. Of course, we were short supply of vaccines initially, and we had more of a triage process in place for vaccines than we did for testing. And so age dependent and so on. So thank you.
All right, Randy, thank you so much. Terrific.